Hello, everybody, and welcome back to another episode of Mind Matters, Navigating Head Injuries and Concussions. I'm your host, Kiley Como. I'm the legal nurse consultant here at Shane Smith Law, and today I'm here with our friend, Dr. Erik Reis with the Neural Connection. Dr. Reis, it's always a pleasure to speak with you. Welcome back to the show today.
Hey, thanks for having me on, Kylie. Good to see you as well.
Thank you. Thank you. Of course, as our listeners hopefully know, our focus here is to discuss all things traumatic brain injury. So, Dr. Reis, let's dive right in. I'd like to get started in kind of from your perspective as a provider, a care provider, expectations. So how do you approach just really setting clear expectations, especially early on in the treatment process, not just for your patients, but other providers you may be partnering with in the care of that patient?
I think it's really important for clinicians to set the standard and make sure that we're meeting patients where they're at. I can't tell you how many times I've created treatment plans or I've said, oh, we're going to do this step, and this step, only to come to realize that one, maybe the patient was never ready for that in the first place, or maybe my expectations were too low or even too high. And so these talking points kind of come from my experience of like making mistakes and taking that feedback and saying, how can I actually do better next time? And so I think early on, for the first thing, I think it's so important to establish that doctor-patient relationship. Your patients are not their diagnosis. They never have been. They never will be. They're a person. They're a human that's sitting in front of you who has a diagnosis, but there's so much more to them. And I think that modern medicine today, where we've really slimmed down the amount of time we can spend with patients, has really done a disservice to allowing us to be able to build that relationship. I think that's the first step. I think the second step too is just trying to be realistic with expectations, right? We want to know, and patients always want to know, how long is it going to take for me to heal? Well, what is the end outcome going to look like? Can I get back to doing X, Y, and Z? And we don't always know that, but I think that there are ways for us to emotionally and psychologically set people up for seeing the benefits for that, right? So we may not ever have an exact timeline, but to say, hey, listen, if we can see this sort of progress in the next couple of weeks and we can start making changes with this, or if you're able to do these things at home, then we're probably going to have a better chance of success. And so I've just found clinically that I've made so many mistakes that I've had to correct them. And Kylie, I'm sure that there are so many things you can share on your side from the clinical side as well too, in some capacity. Those things have just shaped the way that I've looked at it. And now I realize I have to meet patients where they're at. And then more importantly too, I'm just getting better outcomes because of that.
Yeah, you've said it. I find it's kind of I don't want to say tricky, but it is a balance between setting expectations, but still maintaining hope, right? Because that's you've got to have that, right? So what strategy would you say you use to address those maybe unrealistic patient expectations, while trying to maintain that hopeful disposition?
I'm just continuously asking questions. I've realized that a lot of times it's so easy to fill the space with words and sentences and kind of that word vomit that we are all so skilled at in the medical field. And what I'm realizing is that the more questions that I ask and the more that I am able to get out of the patient and or their family members, that's really kind of helped me understand what they're thinking or where their head is. And every person that comes in with an injury, whether it's an auto accident, whether it's a concussion or like a real proper like diffuse TBI, everyone kind of has a different reference point for what to expect or what's going to happen. So I have to gauge that. And then more importantly too, I have to take that information and say, okay, based off of what I've just heard or what I've just been told, how can I now work with them together for us to form a cohesive team to make sure that we are accomplishing the same goal, right? So I think clinically, so many of us, and I'm guilty of this too, like I want to get this symptom to go away, or like, oh, I need to see this objective marker change. And that's great and that's important, but if that's not the biggest problem for the patient, then I'm still not doing them, I'm doing them a disservice. I'm not maximizing what they need, right? If they want to get back up and walk, and that's the only thing that they care about, and that's all that matters to them to have that independence, great. That should be the number one priority on our list, even if they still have headaches, even if somebody still has double vision, things like that, right? Like those other things matter and can facilitate that, but that should be the end goal. And that's, for me, I'm sitting back more and I'm asking more questions than I am giving answers.
I'm so glad you said that. Asking questions is so important. I know, in my own training as a clinician, I was trained to ask 3 specific questions, or teach the patient to ask 3 questions. What is to your point, what's my main problem? What do I see as my main issue? What do I need to do about it? And why is that important, right? So I can really appreciate you obviously have this very patient-centered approach. But every injury, I would imagine you could expand on this, is kind of like a snowflake, right? Everybody's brain injury is so unique. How do you measure progress as a clinician for these individual patients, in the setting of kind of, again, maintaining hope and keeping realistic expectations? How do you find yourself being able to measure that progress with each individual patient?
Yeah. Well, so a couple of things. One, I'm a big fan of objective testing. So we use VNG, video nystagmography, is the extended kind of version of that acronym. And that's doing objective visual testing to look at eye movements. So visual fixation, tracking, kind of depth perception, stuff like that. I like those because those are objective, they're quantifiable, and I can't change those settings, right? So if I, evaluate Kiley today on May 16th, and I evaluate it again in 2 months, like the only thing that's going to change is what we've done to the brain or the nervous system. And I like that pre and post because it gives me conviction, but also can show patients progress too. I think, unfortunately, and we're all guilty of this, we all often forget where we start. And so if I have a patient where it's like, listen, I get headaches every morning, and I'm like, okay, but you have had headaches every morning for the last 3 months, but now you forget that you're also going on daily walks, you're taking care of your kids again, you're doing finances, and you're working 2 hours, but you still get headaches in the morning. Yeah, you're still getting the same symptom, but your capacity has vastly expanded. And I think that that's really an important factor for clinicians to document and understand, but to remind patients of as well too. And so it's that dialogue that's really important. The other thing as well is just looking back. Like sometimes I will read the notes that I've taken on patients because I'm really diligent with my notes to say, hey, remember this? Remember when you were in your new patient examination and this is what you told me and this is how you feel? And they're like, oh, wow, like I forget that I was even dealing with that. I will use my own documentation and the words that they tell me as a way to kind of remind them of where they started to where they're going. And I've found that that's been helpful. It's not perfect, but it's been very enlightening for a lot of reasons.
Yeah, you kind of remind me that the saying, right? The data doesn't lie. So, oftentimes facts and feelings, to use the colloquialism, maybe is not the same. So I like your approach of, while you may feel this way, while you may be experiencing these emotions or these thoughts, the actual facts say something completely different, and that's very important to help people understand that. I think that's a great approach.
Yeah. Yeah, I've just found that it works quite well, and outside of over medicate or medicalizing, we'll say like I need data for every single thing, and it's got to be objective and quantifiable. Like sometimes that's also just exhausting and fatiguing for the patient and the doctor. So I think too much of a good thing could be a bad thing. But too little is also just too subjective, and so there's a happy medium in that. But yeah, that's really like where I've found most success is bringing those aspects to the table.
That's excellent. Well, as anybody who's a fan of the show, watches us regularly, has seen we've had many experts like yourselves on talking about, again, traumatic brain injury, diagnosing, treating, recovering. And one common theme comes up, just about with every expert we talk to, and that is the importance of sleep. And so I'd love for you to really dive into why is sleep so important in the recovery process after, say, a TBI or a concussion, and what are the consequences maybe of poor sleep during that period?
30 to 70% of people who sustain a TBI and or a concussion will struggle with sleep in some way, shape, or form, which is very unfortunate. I mean, and the average standard population of the US, 1 in 3 people struggle with sleep, whether it's insomnia, whether it's, sleep apnea. It's a big problem for a lot of us. And I really feel as though sleep is one of the underlying causes, and also poor sleep is one of the underlying outcomes of just poor health in general, right? We know sleep is very restorative for the brain. When you're sleeping, evolutionary speaking, there's a reason you sleep a third of your life away. When you're sleeping, you are allowing your brain to essentially take out the day's trash, for the lack of a better term. The brain is suspended in cerebrospinal fluid. There are different stages of sleep specifically where that cerebrospinal fluid will increase its rate of velocity, its increased rate of movement to clear out these plaques, these damaged proteins, these things that we don't need anymore. And so that's a really important aspect for just brain health in general. When impaired sleep is inherently occurring, that process no longer occurs, right? And so that's kind of some of the leading theories is neurodegenerative model, just the fact that the brain can't, have this recycling kind of component. We don't really fully know, but that's one of the leading theories. One of the other things too with sleep is that We know sleep is just really restorative. It allows your cells to kind of just heal and allows different aspects of your metabolism to reset. We know that sleep essentially allows you to produce, more ATP, which is like the body and brain's energy currency, right? So when you have more ATP, you recycle the adenosine that you use up throughout the day. And so that's kind of why you feel better in the morning, and then hopefully slowly over time, you know, these breakdowns, these metabolites from that energy currency, the ATP, the adenosine slowly builds up over time to the point where it's like when you have too much of it, now you're getting really sleepy. You recycle all of that stuff in sleep as well. And more importantly as well too, we know that sleep is really restorative for us emotionally and psychologically. So people who don't sleep well inherently have more struggles with mental health. People who also have mental health issues also struggle with getting adequate sleep. It's a vicious positive feedback cycle. So chicken or egg, can't really tell you which one's which. But what's really important about it is to know that sleep is just massively restorative for us structurally, neurologically, metabolically, and emotionally. And so it's one of those things where when you're not sleeping, you can kind of tell. I mean, like when you say, "Oh, we woke up on the wrong side of the bed," it's kind of a cheeky saying, but people really resonate with that and get that. And there's a reason why, is because sleep is really impactful for all aspects of physiology. One of the last points that I'll bring up is that we know sleep actually has a really massive impact on your blood sugar regulation, which is like, oh, well, that's interesting, right? So if what you're telling me is true, then what we can actually look at is how well are you sleeping and how well are you managing your blood sugar. Now, it's not as simple to say, oh, you're going to sleep great, you can eat all the sweets and chocolates and candies you want, right? But we know that sleep and dysregulated sleep will negatively impact your ability to balance your blood sugar and will have an impact on your blood sugar scores, fasting and non-fasting, which I think is just kind of challenging the way we really think about sleep. So we know that there's a lot more to the story, and I would say the average person probably has no idea about half the things we just talked about sleep. So it's pretty impactful.
100% agree. And the discussion of sleep to me always is fascinating. And we've had, several experts on talking about just that. So I think we're gaining a following on this whole, how sleep impacts, right? So I think it's important to dive into, one of the things we try to talk about, or we seem to talk about each time, is the differentiation between sleep and rest, right? They're not the same, right? So we're talking about deep sleep here, like delta waves kind of sleep. That's where you get into that lymphatic system function, and you mentioned that the waste disposal system, if you will. But then you've got these TBI pathologies, like the neuroinflammation. How do those things interplay? How does that throw things out of whack?
Yeah, unfortunately, when you have a TBI, these central processes in the brain that regulate sleep, or even like the production of specific neurotransmitters, and maybe not even the production of neurotransmitters, but like the synchronized release of when those neurotransmitters should be released in specific patterns, all those things can become dysregulated. So I understand the irony of just telling somebody, oh, you should just sleep more, right? Because that never works, right? People know that they need sleep. They know they want to get sleep. So it's a difficult part and difficult process. But yeah, to your question and to your comment about the neuroinflammatory cascade, I mean, those are real things that as clinicians and providers, we have to understand. Now, I can't tell you guaranteed without a doubt that we can just immediately change that, although there are modalities and things that we use clinically in the office that do help. I love using low-level laser. I think that that's a super important modality that can be non-invasive and really beneficial for people structurally, neurologically, and even metabolically. Like I love using like non-invasive vagal nerve stimulators. So I also am doing things that are rehabilitative exercises like belly breathing, humming, singing, which are also a vagal nerve approach or therapy. You're trying to balance the nervous system back out in some capacity, but even more importantly with that too, before I go down like the rabbit hole of like modalities and tricks and things like that, I'm really keen on getting patients to make sure that they have really healthy sleep habits. There's no way out of looking at your habits before you just tackle that as the first and primary intervention. And then after that, everything else you can use clinically, CPAP machines, go get polysomnography testing, all of those things. But until people are actually dedicating time intentionally to prioritizing sleep, I don't have conviction that anything else is going to work, right? So if you're waking up at different times throughout the day, or throughout the week, if you're going to bed at different times throughout the week, if you're eating really late at night, if you're staring at your computer screen or your tablet before you go to bed, like these are things that you have control over that we know negatively impact your quality of sleep. You've got to take ownership on that. And I understand the line between a brain injury that's like, hey, I just had a concussion versus like a full-blown TBI. That's where caretakers and providers have to be having those discussions. So sleep habits to me are always the first intervention. After that, it's things clinically. And then after that, sometimes I just have to send patients out for a referral to say, listen, we've tried stuff. It's maybe not working. Maybe you need medications. Maybe you need a polysomnography PSG test. Maybe we need to like actually have a proper sleep study performed, because I've struck out with patients in the past where I'm like, oh, you just have full-blown sleep apnea and you need a CPAP machine. And those have made big differences for people because they may have structural or even hard neurological issues that just aren't facilitating their ability to get to sleep. So it just depends on what's going on, but that's where the humility in practice comes in, is being willing to try things and then realizing, if you're not getting the outcomes you want, you just got to challenge your thinking on that.
I love that humility in practice. That is a great way to term that. You touched on circadian rhythm, all of that, making sure we're in right sleep cycles. I loved your discussion on kind of those non-pharmacological interventions. I know you and your clinic have a lot of kind of cutting edge methodologies that use to approach that particular issue. So definitely appreciate you laying out some of that for our audience. You did mention blood sugar and how that's such an important factor to our healing and recovery in general, but specifically here with traumatic brain injury. So let's talk about that. So in what ways do those those blood sugar swings? Because it isn't a static number; it's very dynamic, even for normal healthy people. But how do those swings impact those symptoms and maybe that neurological stability in those individuals that might be recovering from a TBI or a concussion?
Blood sugar is an interesting conversation to have, because when you look at like glucose and blood sugar, which are analogous terms, but when you look at blood sugar, like blood sugar is a very reactive molecule. And there's a reason why when we're looking at different types of conditions that occur with people who are like diabetic, we'll say full-blown diabetic, like proper type 2 diabetics, right? You can get things like diabetic peripheral neuropathy, which is damage to peripheral neurons that no longer are functioning the way that they used to, right? You can get diabetic retinopathy, which when you look in the back of the eye, you look at the retina, and the retina is kind of breaking down. There's a bit of tear in the periphery, we'll say, with regards to the functionality of the retina. Well, one of the leading kind of indications for us that we're looking at is that unstable blood sugar levels are very, very destructive to neurons, and we know this because one of the new theories out there now is that Alzheimer's is kind of the new type 3 diabetes. Right? With this dysregulation in blood sugar, what we're finding is that it really pokes holes in arteries and veins, but it also is very destructive to neurons. And so when you have this dysglycemia or this altering blood sugar that's going back and forth, what we're realizing is it's just really disruptive to the neurons. Those neurons then therefore don't function very well. And then those neurons over time will either die off or they're just not going to be able to work as well as they used to. And in some capacity, some neurons you can get back, but some neurons you can't. And once you kind of lose it, you don't get to use it. And sadly, that's what happens with like these peripheral neuropathy patterns. Now, here's what I'll tell you though, is that can some of those things be reversed or at least halted and maybe see some improvement? Yeah, it's by regulating the blood sugar, right? So there are specific principles with regulating blood sugar that we know work really well. It's not just people taking metformin. It's not just doing a GLP-1 agonist and losing weight. It's really your diet, your lifestyle, and your habits, right? So, if you're ever going to eat food or if you're going to, digest food, the kind of thought process or the pattern is how do you eat foods in a sequence or a way that will allow your blood sugar to remain as stable as possible. So instead of getting this big fast spike and then this quick spike down, right, which essentially will lead to you having energy and then losing that energy, and within an hour you're like, oh, I gotta grab Starbucks or candy to get my blood sugar back up. It's this forever chasing cycle of these peaks and valleys. What we know is that if you have food, the sequence matters for how you eat. And so the theory right now is suggesting that if you're gonna eat any food, it's kind of eating like the European model, right? So you have the antipasta first, which is like the salads, some of the proteins, some of the fats. Those things, get into your system, and really it's about the fiber first. So you have that fiber first, which really will allow your body and your gut to feed that gut microbiome in a healthy way. But you'll see this really slow rise in blood sugar over a longer period of time, because it actually slows down the emptying of your stomach. And so if you have fiber first, followed by fats and protein, well, then the carbohydrates later aren't going to spike your blood sugar as quickly. You actually won't absorb as many of those carbohydrates, which I think is super interesting and not well talked about. But the last part about that too is you're going to feel fuller for longer. And so you're not going to be grabbing for snacks and candy and things along those lines. One of the other things that I advise patients on as well too is, we talk about like weight loss and intermittent fasting is a really interesting way to approach that. It's not for everybody, I'll just say that. I've made mistakes with that with patients, especially my female population who are like pre, post, or perimenopause. I have to be careful with that. But what I would say is just taking a walk after a meal is a great way to suppress your blood sugar and get it out of your bloodstream. So whatever you just ate, whatever you did metabolically, 10, 15 minutes, rest, relax, enjoy your time with your company, but go for a 10-minute walk afterwards. What's great about muscles is that they don't need insulin to utilize glucose. And so as you go for a walk, what you're doing is you're pulling blood glucose out of the blood vessels, pulling it into muscles for activation. And it's a great way to lower your blood sugar while maybe not even changing your diet in some capacity. There's ways to utilize basic physiology for that, and that's usually a common theme that I'll give patients.
That's a great summary of. We could dive so deeply into that stuff. I love the sleep, the glucose, the whole lymphatic system talk, and how poor sleep quality creates that vicious cycle, by exacerbating that glucose dysregulation like you talked about. I think we could probably do a whole nother show on that. So
yeah,
that's fantastic.
Yeah, it's one of those things where you need to like have stable blood sugar, and that it's really important, and nobody wants to be diabetic because it comes with a host of issues. But I don't think we've really been educated or taught how to manage it. And there's just some interesting research coming out now. Even the sequence of food, like Kylie, if you and I went out for steaks, we had asparagus and mashed potatoes. You ate your mashed potatoes first, and then followed by your steak, and then your asparagus. Theoretically speaking, if you and I were like identical twins, genetically speaking, we lived our lives exactly the same. If I ate my sequence of food in a different manner, of the asparagus first, then the steak, then the mashed potatoes, our blood sugar levels would vary and different based off of the sequence of food that we ate. So it's not even like the food or the quantity of food, it's now the sequence of the food. And a lot of it involves the release of GLP-1, which is this peptide that everyone's talking about for weight loss. And there's a lot of neurocognitive benefits and cardiovascular benefits that are being looked at now. So it's kind of hacking the human physiology and just giving us a little bit more insight into how that could benefit us. So yes, it's the food, and it always will be, but now it's also the sequence of the food that you eat as well too.
Hacking the human physiology. I love that. I think that could be a great title for the show. So yeah, fantastic. Dr. Reis, I so appreciate your wisdom here.
Yeah, thank you. I'm grateful that you guys always are great hosts and allow us to just be able to have these discussions. I think they're so important for patients.
Same. I love it. Well, everybody, that's going to do it for another amazing episode of Mind Matters, Navigating Head Injuries and Concussions. Again, I'd like to extend our thanks to Dr. Erik Reis from the Neural Connection for joining us today and sharing his knowledge and expertise with us. I hope that you, our audience, has enjoyed this informative discussion as much as I have, and that you've come away with a deeper understanding of brain injury treatment and recovery. As always, please don't forget to hit that like button and then subscribe to our channel to keep up with our latest and greatest content. And if you would, please leave a comment to let us know what you thought of today's discussion. And as always, remember, if you're in pain, call Shane at 980-999-9999. Take care.
In pain, so I call Shane. 980-999-9999. In pain, call Shane.